I think it's an awareness concern. Doctors aren't aware that there's different technologies that are available to help give them objective information to help create a diagnosis. Well, I think the problem is that unfortunately there is no specialty in dentistry for TMJ. So patients go to their dentist trying to find resolution for these issues, and the doctor really doesn't have a basis as to understand what to do. So he usually treats the patient in terms of what his exposure is, which is generally to give a patient a generic night guard or to advise or recommend to get a night guard, which may or may not be the best solution for that patient. It's not really based on a diagnosis, it's just based on a knee-jerk reaction to try to address the problem. Everything that you do to the human body creates a change. So if you have an ill-fitting night guard that a patient hopefully makes somewhat correct, that's generically sized, it's probably not going to be very comfortable at best. So the patient's compliance with that's going to probably be very low. So a step above that would be to get a full arch generic appliance from the dentist, which would cost more but maybe and fit better. But it may or may not be the best solution for that patient, again, because it's not based on a diagnosis of what that particular individual's needs are, but more or less that generic approach the dentist, that particular dentist applies for his one-stop, this is how I fix this problem. One of the first things I think would be to try to assess the level of competency or the level of training and knowledge that the individual dentist has. Or hopefully the dentist would be comfortable enough to say, this is just beyond my realm. This is not something that I know a lot about besides just go get a generic night guard. And one of the things would be to see if he has some of the equipment and technology available to be able to get an accurate diagnosis instead of just putting his fingers in your ears to see if you have a problem with it clicking or popping. There's been a lot of studies done to show us how inaccurate that is. There's only a 14% consistency amongst diagnosis with people using a stethoscope. That only goes up to 48% for a very advanced stethoscope called a Doppler. But the JVA, which is a technology that's available, we can actually get a 98% sensitivity and specificity to determine if there's a problem with the joint. Part of our diagnostic process is set up to make it as benign as possible and to make it scalable so that basically the patient can come in and they can actually have the JVA quick test done, which is very, very simple. It's just two simple sensors that look like headphones that go onto the ears. There's zero discomfort, there's zero pain, and it's within a minute we can tell exactly what's going on with that patient's joint. And seeing, is this joint itself part of this patient's problem? With TMD, there's 31 different diagnoses and etiologies that are associated with what can comprise this patient's individual problem. So it's not as simple as just coming in and putting in a night guard and hoping it works. It's a better approach to sit there and have a method and methodology to be objective about your diagnosis, your evaluation, and your treatment of that patient. The JVA Quick is the cornerstone in my practice for that because it allows us to eliminate so many of those different diagnoses or possible etiologies to get a better feel for what this patient's problem is, and therefore we can become far more directed. We can definitely become far more directed in terms of how we approach this individual patient's needs. And it's very easy. It's very benign. There's no pain. There's no discomfort. It's a very quick, easy test. 65% of the human population has a joint that makes some form of noise. NIH did a study where they found that between 4 and 15% of the population of patients have pain, discomfort, or dysfunction that would benefit from treatment. And that amounts to hundreds of patients within an individual dental practice for every practice in the country. So it really, instead of just saying, well, 95% of my patients are okay, there's actually 5% or 10 or 15% of my patients that I might be able to help. And that's where this kind of technology is invaluable for giving people guidance in terms of how to appropriately address and treat these patients. Absolutely, and that's the reason, again, that we use the JVA Quick routinely on all of our patients all of the time. Because there is no specialty in dentistry for TMJ, it really behooves the individual practice to have protocols, treatments, and methods to assess their patients. So every one of our patients that comes to see us routinely, just like you get x-rays from your hygienist, well, they routinely get the JVA Quick from us. So we can actually get a baseline. And getting that baseline is critical, so that if we see a change, the patient a lot of times can have an understanding that, well, my situation is getting a little worse, or what is that all about? I've never really been given any information on that and understanding that. So we found it opens up a whole floodgate of abilities for patients to understand and explore these things instead of just ignoring them and putting them aside. It can be quite debilitating. I think there was a study done just recently that showed that of 100 million Americans, out of every 100 million Americans that are out there, there's 17.5 million work days lost every year due to specifically TMD. So it's a pretty significant issue. It's not something that is unfortunately addressed as often as it should be, but it's a significant issue, obviously from even the workforce standpoint. It's been around since as long as we've had human beings. But there's an interaction, actually, it's not just TMJ, it's actually the better term for it is TMD, which is temporomandibular dysfunction, which includes issues with the joint itself. Again, there's 31 different etiologies that come into play with TMD, dysfunction in the actual joint itself being one of those. That's been around forever. The stomatognathic system, which is a fancy way of saying the teeth, the muscles, and the joint, all combine to create whatever that human being has as their way of functioning. So disruption in any one of those systems creates an imbalance that obviously can become symptomatic for them. And that's where the 6 to 15% of the population falls into, is an imbalance that's no longer something that they can tolerate, that creates a dysfunction that actually can affect their lifestyle. And we see a lot of that. So I think that's something we shouldn't be overlooking and ignoring, trying to console ourselves that, well, 90% of my population of patients is okay. So, okay, I'm not going to address this other 10%, and that 10% is a large number of people in the United States. Well, I think it's a lack of understanding of the diagnostic process. And what that means is that most patients go to a doctor assuming they're going to get a diagnosis, and just give me a diagnosis, give me medication, or whatever it may be, and off I go. And that's not how the process works. And with something as complex as TMD, where you have 31 different etiologies, it really mandates that you're able to have the training, the equipment, the knowledge to be able to understand which of those 31 is this actual patient's problem. So the diagnostic process truly is where you come to the doctor with your symptoms, and he goes through a series of tests, one being the JVA, and getting an understanding then of, well, how does this part play into it? And by getting all of the information, you create a differential diagnosis, which means that this patient comes to me with this problem, and it could be this, 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 or this. All of the data steers more towards the likelihood that it's this one problem, so I'm going to use that as my working diagnosis, which is the one I'm going to work off of to see if in fact this is this patient's problem. And then from that, you actually treat the patient on that working diagnosis. And it's only after you successfully treat the patient that you can actually say that's the definitive diagnosis. So most doctors that I run into don't even have that basic understanding of the diagnostic process. And I think that it's imperative, if you're going to be approaching TMD issues, that you absolutely have that incorporated into your practice. There's a lot of reasons. It could be something wrong with their actual teeth in terms of how they come together. There could be a psychological component, in fairness, stress. We know that basically bruxing and grinding is a natural human stress release mechanism. that you actually incur when you're exiting the fourth stage of sleep, which is the deepest stage of sleep. So you can't know that you're doing it and be doing it. So you can't be in the deepest stage of sleep and know you're in the deepest stage of sleep. But there's a period of time for up to 15 minutes during each sleep cycle that a patient naturally bruxes in, especially during stressful periods, which is a parasympathetic activity, which is an attempt to get your body back to more stability from the increased sympathetic tone that you have being stressful, being stressed out. So if you multiply that times the 6 to 8 hours that a person would sleep, that's up to 2 to 3 hours of bruxing and grinding your teeth every single day. It's been studied actually how long human teeth should and do physically contact. And some studies go as low as 15 seconds in a 24-hour period, up to 15 minutes. But that's the maximum amount. Chewing, eating, etc. Because you never touch, teeth never touch. That's the irony, is that teeth never touch. There's food in between if you're chewing. They glance in milliseconds, and when that's all added up, it comes out to 15 seconds to 15 minutes is normal in a 24-hour period. So it's pretty apparent then, if you're bruxing and grinding for 2 to 3 hours, that you're putting this system, which may or may not be stable, under a lot of strain, and that's how human beings end up with these problems. They put this system that may not be accurate or balanced enough under a lot of duress, and therefore it has a tendency to possibly break down in either the teeth, the muscles, or the joint. It's not just clenching and grinding, but there's a wide compendium of how people respond to this. There's a large degree of human beings' capacity to accommodate. Say dentistry that's been done can change things. Your mouth and your teeth are very, very, very sensitive, that you can pick up 25 microns difference in the human tooth structure. So you can literally find a discrepancy in 25 microns in your teeth that the patient can perceive, which is 1/5 the thickness of a human hair. So imagine when you're putting a crown in that's not quite right, you're going to try to find a way to get around that or work around that. So we've seen a lot of times where, if dentistry is one of the issues that can possibly make it where patients say, it never felt right after I had this crown done, or they may have never had that right, or they had orthodontics done and it didn't quite feel right. So if you're not looking at the bigger picture, and if you're not aware of that, and if you're not trying to pay attention to that, then you're going to just hope that that patient can accommodate whatever you've done. I like the approach of trying to understand where they're going to go, and then trying to help them get there, and understanding these issues so that you can get a better outcome. So we've seen a wide range of patients. Some have had no dentistry done and have a significant issue. Some have had a lot of dentistry done and have a significant issue. There's a lot of etiologies, again, that lead into these problems. We've actually had a lot of different types of etiologies. One very interesting one was a referral from a doctor in London. The patient had visual snow, and it's very interesting. Basically, he has an issue where he constantly sees, like on a TV screen, you see the snow, visual snow. That's his environment. So there's a lot of work that some of my colleagues in London have found where there's orthopedic and orthodontic issues that cause pressure on different arteries and veins through the actual neck, through the atlas, that actually impinge upon the blood flow into that region of the brain, which can cause these issues. So we actually look at not just orthodontics, we look at orthopedics, we look at the structure of a patient, we look at the entire body to see how does the entire system play together, and does it play nicely. The most significant part of that, though, is not just using theory and conjecture, but I'm a strong advocate of using data and equipment and technology to get facts so that we can build our responses and our diagnosis and our treatments on that. So visual snow is one of the most unusual ones. We've had times where we've done a certain approach, where we've tried even our approach, and it didn't quite give us the results that we initially expected. But again, everything is telling you something if you're aware of what it's telling you. So there is no such thing as a bad result. If you wore a night guard from a drugstore and you put it in your mouth and it actually made your problem worse, then that's telling you something. It's just a matter of, are you aware of what it's telling you? I think that's the biggest key, is you have to have that diagnostic process as your foremost mantra of how you're going to approach these cases, and then you'll find your success rate goes way up. That's a great question. Sometimes we get relief as soon as we can start any procedure with them, such as the night guards, right away. We have a patient that I think you're going to see today who is a doctor. She's a chiropractic doctor, and she saw immediate relief. We have another patient who tried the same approach, and again, we call it a diagnostic appliance. If it actually gets rid of your pain, then it can become a therapeutic appliance. But everything is steering us towards an outcome, a positive outcome for that individual patient.